we've been talking around all of this in terms of therapeutic options and transfusions, and I know we're going to get down in the weeds on this in a little bit. So this might be a good time to back off, take a 10,000-foot view, and just review our options. What are the standard therapeutic options for the anemia of chronic kidney disease? I heard iron. We might as well start with that.
Well, I think first of all, to Dan's point, there are certain basic demographic issues. So what stage of CKD becomes important in the workup? For the average CKD patient who is anemic, there are several things you need to do. Obviously, you need a CBC. Obviously, you need to know that iron is present. That would be the absolute baseline. Based on that, okay, in chronic kidney disease, which to Dan's point is an inflammatory state, if iron stores are adequate, then the decision whether or not to treat needs to be made. If they're iron deficient, they need iron replacement, in which case you would start looking for a reason for iron deficiency. Dan?
Yeah, I mean, our treatment options are oral iron, and there's a number of products that are available. There is one type of oral iron called Arixi or ferric citrate, which can be given in really high doses if they take it with meals. And the reason I bring this up is this stuff looks, if they take it over a 3 to 6 month course, is equivalent to giving them IV iron of a substantial amount. But right now it's priced very expensive. So that's a second option. And then third is to give them various forms of IV iron, generally to a total dose of about 1,000 milligrams infused. That can treat iron deficiency and helps the anemia quite a bit. And then after that, ESAs or erythropoiesis stimulating agent. That's epoetin, darbepoetin are the major ones.
Yeah, we'll get to that. But just before we leave iron, the rap on iron has always been its tolerability, oral iron,
Yeah.
and it's constipating. It's really constant. A lot of patients just hate it.
Yep.
I could tell you in my household, one of my family members was severely anemic post-op, would not take it.
Yeah.
I mean, is that your experience with it?
I think there's a lot of variability. So I never, you know, the classic is to tell them to take a pill 3 times a day, and I never tell them that. I tell them to try and take it once a day, and you know, if we can keep you on it for 4 months, there's a good chance it may help. But many insurers require us to demonstrate that they've either failed oral iron or cannot tolerate it. And our guidelines also recommend oral iron is the first choice because in randomized trials, it's really about as good as getting a moderately high dose of IV iron. So why not give it oral? You avoid the IV cost, the risk of IV medications. It's a reasonable first option, and it's cheap.
I think that to Dan's point, and I just want to build on this because these patients are complex. To your point on the diet, our patients are usually on a restricted diet by the time they're anemic.
Right.
Secondly, I am a big proponent of minimizing the pill burden. Our patients on a huge number of medications, to see multiple physicians. You know, I think a wise practitioner looks very carefully at the medications and the interactions and the cost for that matter. So I agree with Dan, a trial of iron is reasonable, but I have just not been as lucky at its outcomes as he may have been.
From an insurance perspective, iron's cheap, right?
So iron is cheap, and typically, Dan's correct, most payers will require some form of oral trial. And of course, if a patient can't tolerate it, then that can be clearly documented in the medical record. And then you advance to the next step, which is some form of IV iron.
So you use the word step. Is that the insurance company's phrase for stepwise will escalate?
Step therapy, correct.
Yeah, I thought I was going to hear it eventually. Is it necessarily a bad thing for the insurance companies to want to do some sort of step therapy here, guys?
Well, our guidelines say that should be the first therapy, so I don't think it's inappropriate. You know, there's not very many cases where I object, and it's really when the anemia is pretty severe and I'm very confident they'll respond to iron, and I want to give it IV to speed up the response rate, and not take a chance that I've wasted 2 months on them not responding.
So you would, if I hear you correctly, you'd start iron, but you'd monitor this, and if they're not responding, then you'd move on.
Yeah, well, if you can say, look, they're really bad. I mean, I really have not had trouble with insurers turning us down when we want IV iron if we've made rational decisions along the way. Sometimes we've given oral iron. Sometimes we said, look, it's really bad and we need this to go up fast, so we want to give them IV iron, or I'll pull out EPO. So then I threaten them with the cost of EPO. And then all of a sudden they're way more interested in giving me IV iron. It's a win-win in my view.
All right, now you did mention, and I said we would come back to it, so I'm going to keep my promise. Get off of iron for whatever reason. You want to move on to erythropoietin stimulating agent therapy. And I'm assuming the reason you want to move on is the iron isn't working very well. So what would be the indication to move on from a clinical perspective?
The hemoglobin's too low in the opinion of the nephrologist, which for pretty healthy people is hemoglobin's persistently in the 9s. I usually say, look, if it's going on for the 3 months, they're going to stay there, and now's the time to pull it out. But in my elderly, more disabled patients, I may wait until they're persistently in the 8s to deal with the expense of EPO, recognizing that it's changing the hemoglobin, but it's not changing their cardiovascular outcomes, and it's probably not going to make them feel better.
Stan, what are your guidelines? What do you do in your practice?
So in my personal practice, because I practice as well, I agree with Dan here. I do the same thing. From a populational standpoint, though, we try to toe the line with the KDIGO guidelines, which, as Dan indicated, requires some form of oral iron. And then we tend to watch KDIGO's recommendations in terms of hemoglobin. So we don't start people above 10. So if you're asking for an ESA, for example, in a patient above 10, that's not indicated based on guidelines. So something like that would be probably not allowed. But very similar, again, we're sticking with the guidelines as we see them in terms of strict evidence.
The guidelines that I've seen from, it's KDIGO, right? I'm not a nephrologist, but I listen carefully to you guys. The guidelines read like they're written by committee. Not that they're bad, but they read they're carefully parsed. And here's a quote that you're going to balance the potential benefits of transfusion reduction and anemia-related symptoms against the risks of harm. Well, okay, but reading that doesn't tell me very much.
But Peter, I think, first of all, I agree with everything Dan and Stanley said, but as a physician, this is what we know. There's population health, in which we make some high-level decisions, and then there's an individual sitting across an examination table from you that you make a one-on-one decision. So for example, if I have an elderly patient with a hemoglobin of 8.5, who now has recent acute cognitive dysfunction, I'm going to treat the anemia, right?
Right.
So I think we need to be careful. Population health is important, but then you have to take that information and apply it to an individual.
That's where I was going. Your patient is an N of 1.
Yeah.
And whereas an insurance company, and I don't mean this in a negative way, has got to make plans in terms of population dynamics. You've got somebody sitting across from you who says, I don't feel well, and my hemoglobin is 9. What are we going to do about this?
Yeah, I would just add, because Stanley is right on point, physicians must advocate for their patients, and they always have. The difference in the 21st century, our advocacy is translated into a lot of paperwork to get approvals that is very time consuming. So that is the conundrum we're in.
So I do think that we tend not to, when we see a patient and we're talking about using ESAs, the factors that I look at other than the hemoglobin is what's their cardiovascular history. We know these class of drugs, at least when they were targeting a normal hemoglobin in the TREAT trial versus placebo, doubled the risk of stroke. And if you had a prior stroke, it about tripled your risk. So I joke that there's two types of patients that I offer ESAs to. Those who agree and have never read the package insert, and those who have read the package insert and never agree. So the second thing is cancer risk. If they've had a prior cancer or have an active cancer, it's probably contraindicated, depending on the various issues, to really be using these products. So you have to really have risk benefit shifts greatly against using these drugs. So the truth is we make those decisions all the time. I've never had a prescription for an ESA turned down by an insurer, but there are many times where I'm sure the insurer would have approved it, and I don't think it's good, and the patient's certainly not going to take it.